Here we will discuss about mysthenia gravis. Mysthenia gravis is an autoimmune disorder affecting the myoneural junction. Is characterized by varying degrees of weakness of the voluntary muscles. So in this disorder we can see weakness of the voluntary muscles. So this mysthenia gravis is a autoimmune disorder and it is affecting myoneural junction. Myoneural junction means the junction where the neurons is attaching or targeting muscles. So it is a junction where muscles and neurons are connecting. So that is myoneural junction. Normally the acetylcholine attaches to the receptor sites on the motor end plate, stimulating muscle contraction, which means normally if you see a myoneural junction in the neuron, from the neuron, the end of the neuron, I mean the axon area, there will be some receptor sites where acetylcholine will be there. Acetylcholine will be there in that end of the neuron site, and this will attach with the, or it will contact with the muscle area. So because of this acetylcholine, this neuron will stimulate the muscle contraction. So when a muscle is moving or contracting, what is happening? There will be one neuron or the end of the neuron. You can see acetylcholine. This acetylcholine is producing the muscle contraction. But when you see in mysthenia gravis, autoantibodies directed at the acetylcholine receptor site. So in mysthenia gravis, autoantibodies are coming and it will attach the area where acetylcholine used to attach. So instead of acetylcholine, you can see autoantibodies will attach there. So what will happen? Normally there will not be impaired transmission of impulse across the myoneural junction, because before acetylcholine was there, so that's why there was a proper stimulation of the muscle or contraction of the muscle. But now there is no acetylcholine. Instead of acetylcholine, autoantibodies are directed and they are attached to that area. So there will not be any proper stimulation, resulting in voluntary muscle weakness. So the muscles will show weakness because muscle is now not getting a proper stimulation or contraction because there is no acetylcholine. Instead of acetylcholine, in that receptor site you can see autoantibodies. Again I am telling, the myoneural junction means the neuron where the neuron is attaching the muscle. So that is the myoneural junction, a junction or a place where neuron and muscle is connecting. Okay, the risk factor, actually the exact etiology or cause is unknown. Still it believed that thymic hyperplasia or thymic tumor is a risk factor. Actually it believes that thymic gland or thymus gland is producing this type of autoantibodies, it believes. So there is a risk factor. If the patient is having thymic hyperplasia or thymic tumor, there is a chance for getting this mysthenia gravis. Clinical manifestation, you can see diplopia, double vision, because here what is happening, your muscles are getting weakened. So your eyelid muscles or muscles attached to the eye, all are getting weakness. So you will have diplopia, double vision. Ptosis means drooping of the eyelids, that is ptosis, because eyelid muscles are weakened now, so you will have ptosis. Then weakness of the muscles of the face and throat. When the patient face muscle is weakened, you can see a bad expression, or the facial expression will be different. Then generalized, all over the body there will be generalized weakness. Then dysphonia or voice improvement, because the muscles near the laryngeal area will get weakened, so there will be dysphonia. Then risk for choking and aspiration, because as you know, the muscles related near to the trachea or the intercostal muscles, or muscles which helps for swallowing or the muscles which helps for breathing, all are getting weakness. So there is a chance for choking and aspiration, weakness of intercostal muscles resulting in decreased vital capacity and respiratory failure. Assessment and diagnostic findings. To find out this mysthenia gravis, the best assessment is anticholinesterase test. Anticholinesterase agents stop the breakdown of acetylcholine. So normally in this disease, what is happening? The acetylcholine is getting breakdown by autoantibodies. So if you give anticholinesterase agents, then there will not be any breakdown of acetylcholine, so that there will be thereby increasing the acetylcholine availability. So normally in this is what is happening, autoantibodies are coming and it is breaking down, or it is removing the acetylcholine from that area. So if you give anticholinesterase agents, so it what will happen, the autoantibody cannot work there, then you can see lot of acetylcholine in that area. So this is the base. So anticholinesterase agents stop the breakdown of acetylcholine. So here we will give edrophonium chloride is injected intravenously 2 mg at a time to a total of 10 mg. So we will give edrophonium chloride, which is a anticholinesterase. So we will give this 2 mg at a time to a total of 10 mg. 30 seconds after injection, facial muscle weakness and ptosis should resolve about 5 minutes. So after giving injection of 30 seconds, if you check, you can see that this facial muscle weakness problem and other problems are resolved. It means it is a positive test. So what is happening here? Before there was no availability of acetylcholine. So if you give these anticholinesterase agents, example edrophonium chloride, what will happen? There will not be any breakdown of acetylcholine, and you can see a lot of acetylcholine in that area. So if there is acetylcholine, there will not be any facial muscle weakness or ptosis. So here, because after giving this medicine, if the facial muscle weakness and ptosis is resolved, or the facial muscle weakness and ptosis problem is not there, which means that it is a positive test for mysthenia gravis. Management: we have to give anticholinesterase agents. As I told, if you give anticholinesterase agents, it will stop the breakdown of the acetylcholine, and it will make available enough acetylcholine in that area. So acetylcholinesterase agents, example pyridostigmine bromide and neostigmine bromide. Also you can give corticosteroid, because it's an immunosuppressant. If you give a corticosteroid, the autoantibody work will be decreased. There will not be decreased autoantibody production, so that this problem will not be there. So you can give corticosteroid. Then plasmapheresis means in these patients, plasma and plasma components are removed through a centrally placed large bore double lumen catheter. So through a catheter you will remove the patient plasma and plasma component. After that you will separate blood cells, and antibody containing plasma are separated. So you will from that plasma we will remove this autoantibody. After that, after separating, you will again reinfuse this plasma substitute. So here through a double lumen catheter you will remove the plasma, and from plasma you will separate this antibody. Then after that, this plasma substitute you again reinfuse. Then surgical management is thymectomy. Thymectomy means surgical removal of the thymus gland. So these are the management. Thank you.